Good evening, everybody. I welcome you all to the CPD session on back pain in primary care, conducted by Sri Lanka College of Specialist Family Physicians. Today, our resource person is Dr. Anuradha Jayanath Paranagama. He is the acting consultant orthopedic surgeon of Neurotrauma Unit NHSL and DGH Neurological. He has obtained his MBBS from University of Colombo, and he has done orthopedic surgery in PJM Sri Lanka, and he was trained in spinal surgery in United Kingdom. So for our college, on behalf of our college, I thank you, Dr. Anuradha, and I thank you all for joining with us today for this CPD session. And before we start, let me remind you of some housekeeping rules. Please keep your microphones muted. And at the end of the session, we will be sharing a Google form and you have to fill it out to obtain the CPD certificate. And to obtain that, you have to be in the session throughout the session. According to the National CPD Committee guidelines of the Sri Lanka Ministry of Health Sri Lanka. So I hope you would use this session to update your knowledge. Dr. Anuradha, over to you. Dr. Anuradha, we can't hear you if you are speaking.
Hello.
But now we can hear you, sir. Previously, we did not.
Thank you very much.
Yeah.
Today we are starting on the back pain in primary care. So, why is it important? Is back pain is the second most common reason why people consult the primary care physicians, and the respiratory tract infections are the first. And 90% of adults will have lower back pain at some point, and the leading cause of work disability in those less than 45 years, and one of the most expensive, probably the most expensive cause of work disability, losing more than 650 billions of US dollars per year. So the outline is like that. I will have already told about the importance of back pain, and to build up on the lecture, I'll talk about some functional, anatomical, and physiological points, and we'll talk about the pain generators in the spine and how to evaluate a patient with back pain in primary care with a bit of detailed analysis on how to evaluate a patient, and several important conditions and exercises therapy and physiotherapy in between, how the things going on. So the back pain and location is important. From neck, C1, we call the occiput as C node, and from C1 downwards, C1 to C7 is called cervical vertebra. So we put that area as the upper back, and mid and the up. We call that area as the neck, and the mid and the upper back comes in the thoracic area. In terms of not the actual thoracic vertebra, that is mid and upper back is T1 to T12, And the lower back is considered in L1 to L5, sacrum and the coccyx. So in considering the location of the back pain, most of the back pain occur in the lower back, that is around 50 to 60%, and the cervical back pain is 20 to 30%, and the thoracic back pain again 10 to 20%. Although it is 10 to 12, 20% in thorax area, the importance of thoracic back pain we can't ignore, because most of the sinister causes like infection and the tumors occur in the thoracic area. So just to recapitulate on the development spinal curves, we have two kinds of things to talk about is the spinal column and the spinal curves and the spinal cord. Uh, uh, in the fetus, only the primary curve is there. So the first secondary curve is cervical, and that develop the first secondary curve. And the second secondary curve is in lumbar, which helps to get the erect posture. So in spinal cord development, there's a differential growth in the spinal column and the cord. So that makes in fetus at the 8 weeks, it is it comes to the whole length of the column, and at 24 weeks, the differential growth we can observe, and in newborn, the actual spinal cord ends at the level of L3, and the final phylum terminale, which is still anchoring into the S2. So in adults, as we know that column ends at the level of lower border of L1, and it causes some differential growth features, like in cervical. We have a corresponding segment is one level higher, and in upper thoracics, it becomes 2 levels higher, and lower thoracic again the 3 levels lower. In lumbosacral, it is T10 to L1, because the actual codes end at the level of L1. So after lower border of L1, we have the Cauda equina, one of the most important regions in case of emergencies. So finally, the phylum terminale is anchoring into the S2. So root to pedicle relationships also important, because we know we have two kinds of roots in lumbar spine as well as in cervical spine. We have in between, if you consider L4 and L5, in between L4 and L5, below the level of the L4 pedicle, the L4 nerve is exiting, and at that same level, we
Sir, we can't hear you. I think he was
We
disconnected.
can hear you, please, sir. We can hear you.
he was disconnected. We'll try to get him back.
Sorry for the interruption. There's some interruption due with the internet connection. So we were talking about the root to pedicle relationship, and in lumbar spine and the cervical spine, we have lumbar spine, the root goes under the numbered pedicle, and in cervical spine it goes above the pedicle due to the growth. So in growth of sitting height as a growth of spine, in females and males, there's some differential growth. Only the 30% of spine is ossified, and the sitting heights directly reflects the growth of the vertebral height. If you can see from newborn to 5 years, there's a large growth spurt in both the males and females, around 27 centimeters, which causes which is the highest growth in the spine at the period from newborn to 5 years. So finally, what happens is this: you get the cervical vertebra, which you can put the thumb, and you have the lumbar vertebra, which you can put your index finger, and the thoracic vertebra, which only the small finger can be inserted. This is very important because this means the relative area we have for the cord. In case of cervical spine, although it is very important, we have a lot of space to deal with. And in case of lumbar spine, we have a relatively large space than the thoracic spine. So in thoracic spine, we have the cord, as well as it is very narrow area. So it is unforgiving in case of spinal cord compressions, as well as in trauma. So this area of area we have for the cord is very important in relation to the spinal pathologies. So just to recapitulate on the forces on the spine, we have bending moments, and we have shear, and we have compression forces on the disc. The same movements of bending and compression we could get in a case of the same kind of movements occur. If we think about the normal standing person's disc pressure as 100, in lying flat on the supine position, it is around 25%, and on side again 75%. If you bend forward on standing, your disc pressure goes up, and if you have weights on the hand, the disc pressure further goes up. If you are sitting, again, it's not like standing. There's a difference in sitting and standing. We have the higher disc pressure here. If you bend forward in sitting, again, disc pressure goes up. And if you have weights in the hand, you have a lot of pressure on your disc. So there's a concept of functional spinal unit and spinal columns in discussing about the back pain as well as the spinal pathologies. So we have a functional spinal unit consists of the superior vertebra and the superior end plate, and we have intervertebral disc here, and the inferior end plate and the inferior vertebra. This all consists of the functional spinal unit. Intervertebral disc, end plates together, and the superior vertebra, part of the superior vertebra and the part of the inferior vertebra. the anterior part of the vertebra, which actually consists of the spinal column, take around 70% of the body weight and 70% of the load, whatever the posture. And in case of the posterior elements, the facet joints take around 30% of the weight. The anterior, we have a theory of columns, spinal columns, which causes the how the spinal pathologies occur. We have anterior column, which consists of the anterior two-thirds of the body and the anterior longitudinal ligaments, and the middle column, which has the one-third of the body, and the posterior longitudinal ligaments and the posterior column as well. So, what happens in degenerative disc? And in healthy disc, we have the vertebral body and the innervative nerve fibers, blood vessels, end plates, capillaries, and the cartilaginous end plate, and the nucleus pulposus, disc, and the annular fibrosis, as we know. What happens in degeneration is we have some calcification in the end plates, causing the blood vessels can't penetrate, and loss of demarcation in the annulus as well as the nucleus pulposus, and uh, it causes the low oxygen environment here, causing the nerve ingrowth. And the osteophyte formation, loss of disc height and loss of hydration, and discuss around 70% of the compressive loads going through the anterior part of the spinal column, which consists of the disc and the vertebral bodies. So, how the biomechanics change after disc back pain. And in case of normal disc, we have a load of 44% here in the anterior most part, and load of 48% here in the posterior part. And in the posterior facet joints, it is around 8%. So with the degeneration of the disc, what happens is your load goes towards more posterior, causing further degeneration of the facet joints. You have degeneration of the disc here, and disc height goes down, and load bearing ability and your load to withstand the compressive load, the load bearing ability goes down, and the facet joints arthropathy to start with the degeneration of the disc causes the higher loads going towards the posterior part of the facets. So just to discuss some anatomical features of individual, we are not the same actually. We have different spino-pelvic harmony. So the spinopelvic harmony is one of the things which leads to the back pain in individual things. Now they are bringing up a genetic basis of back pain as well. So this is one of the things, one of the tangible things. So we can see how spatial arrangement of the spine in relation to the pelvis causes the back pain. We have three parameters, that is the sacral slope in relation to the line, horizontal line, and we have the pelvic tilt in relation to the vertical line, and we have a concept called pelvic incidence, which is the collective value of pelvic tilt and the sacral slope. And the pelvic incidence, low pelvic incidence is associated with chronic lower back pain and lumbar instability of the L5S1 segment to be associated with the low pelvic incidence. So the parameters are around 40 to 65 degrees, and the sacral slope is 30 to 50 degrees, and the pelvic tilt is 10 to 25 degrees. So that is based on individual values. So it's different from one person to another, but the total is kept at a constant. So some people are more prone to back pain due to their spatial arrangement of the lower pelvis in relation to the spine, and the spine in relation to the pelvis. So what happens is, from normal to kyphosis, and we have thoracic kyphosis and lumbar lordosis and the cervical lordosis as well. So what happens finally is, when you get the from normal person to the total kyphosis, you have hyperlordosis of the cervical spine and reduction of the thoracic kyphosis to compensate. The spine needs to keep your head over the pelvis. Then what happens is, to as a compensatory mechanisms, with the degenerative things occurring, and your spatial arrangement of the spine in relation to the pelvis changes, and you get hyperlordosis. The neck is extended more, and your thorax become thoracic spine become more extended, and you get some things called retrolisthesis of the lumbar spine and the hyperextension of the lumbar spine, and then your pelvic tilt backwards, and your knee become flexed, and your ankle become extended, and these are the compensatory mechanisms due to the spine balance, and when you become the imbalance. So all these things are important in making the back pain, how we consider how the back pain is occurring. So next thing is how what are the pain generators in the spine. Our spine is innervated with the nerves we call the facet joints, and the disc, and even the periosteum, blood vessels. All these things are pain generators. So we have the nerve here, and we call the main branch which is supplying the facet joints as the medial ramus, and the disc, the posterior part. So we have the anterior ramus, posterior ramus, and the recurrent meningeal nerves, and the sympathetic trunk, and the gray rami communicantis. So all these things, structures, are causing the back pain, and all are back pain generators. So the main things: disc, bone, joints, ligaments, muscles, nerve root, everything causes back pain and contributes to the back pain. So how to evaluate a patient with back pain? We have a 10 points history. One is your pain. Pain, the site. Ask to point with one finger, whether it is cervical, thoracic, low back pain, or the SI joint pain, and ask to point out all this. Otherwise, we can't find the proper place. Point out with one finger is very important. And the duration, if it is acute, it could be trauma or infection. It is 3 weeks. And if it is subacute, 3 to 6 weeks. And chronic is more than 6 weeks. And radiation is important, whether it is only the back or back pain radiating to arm or leg. Is back pain or the leg pain. And aggravating and relieving factors: standing, bending, walking. Pain in any other joints, whether it is polyarticular, ankylosing, or rheumatoid arthritis. We can get a picture on that if you have pain on any other joints other than the spine, and the treatment taken so far in response to treat NSAIDs, opioids, etc. So pain is all these points are important. We call the spine history as 10 points history is slightly different from the normal clinical evaluation. So next point is we are asking about the walking. How far can you walk in minutes or distance? It's vascular versus neurogenic claudication improves with bending in case of the the lumbar canal stenosis. It gives more space. And improves on cycling and bending them. When in case of lumbar canal stenosis, the bending movements gives more room for the spinal column, more room within the spinal column for neural structures. So it causes relieving the back pain. And next is has the walking distance reduced over time. That is progressively worsening type of neurogenic claudication. And third point is feeling of weakness in any of the limbs, whether you have foot drop and hand or grip weakness, and in triceps weakness is there. And the bladder and bowel weakness is the fourth point. And can you feel your bladder? Can you feel your back passage while cleaning with the toilet papers or water? And that is very important to know about the loss of the perianal sensation. Do you have control when you're passing water? Whether you can stop the flow of urine to see how we can voluntarily activate the sphincter function. And fifth point is the are you able to questions? The spine history is slightly different from the rest of the history, as I told. Are you able to do the washing and dressing? Are you able to stand for a prolonged period of time? And are you able to sit for a prolonged period of time? Are you able to sleep comfortably? And how's your social life? And do you use a walking stick or crutch? Next point is about red flags. Red flags, main things, mainly four things. If you have forgotten the rest of the things, just ask about the night pain and the weight loss and fever and the history of malignancy. Those are the main four things. And to elaborate on the red flags, common red flags are to differentiate between the fractures, metastasis, infections, and Cauda equina. Those are the most sinister pathologies. So we have the regional in relation to the region, cervical, thoracic, lumbar, or sacral or coccygeal. So mainly the fractures comes in recent history of trauma, fall, road traffic accidents, in minor trauma, in case of osteoporosis, that also very important. And vertebral meds, the night pain, rest pain, we'll talk about the meds separately. And the spinal infections, the IV drug abuse, and the constitutional symptoms, fever and chills, the history of prolonged corticosteroid uses. And Cauda equina syndrome, we'll talk about that separately, as it is very, very important, one of the emergencies presenting to the primary care. So what are the yellow flags? Yellow flags are also discussed in spine. Those things are psychological factors mainly. It increases the risk of developing or perpetuating long-term disability and the work loss associated with the lower back pain. So we have belief that the pain and activity are harmful, and we think that this might cause my spine worse. And sickness behaviors, low moods, and treatment belief do not fit best practice, uh, and problems with claim and compensations, history of back pain, time off, those kind of psychological things, set of psychological things are going on. So next is we have Waddell's signs of detective psychogenic or non-organic lower back pain. Uh, we have 5 categories of Waddell's signs, which was introduced in 1980 by Professor Gordon Waddell. And we have tenderness in the lower back. We have simulation, distraction, and regional disturbances and overreaction. So tenderness is superficial and it is non-anatomical, and the simulation is axial loading causes lower back pain, not the actual one, but simulation also causes. Rotation again causes the lower back pain, and the distraction it inconsiders limitation of straight leg rest, and supine and seated positions we can do to see whether it is true neurogenic pain is there, and the regional disturbance of weakness and sensory is there, and the overreactions is disproportionate verbalizations, facial expressions, those kind of psychological things also associated with the spines. So these yellow flags and the vital signs to identify the non-organic things are the psychological component in identifying the actual non-organic features. So what are the other features, other points? The 7th point is the what treatment do you have already taken? The physio, surgery, past surgeries, surgery details, and the past history. Again, 4 questions. The medical, diabetes, hypertension, and the normal medical things, and the major past operations, the rest of the operations other than the spine, and the medications, mainly steroids, blood thinners for surgical planning, and the immunosuppressants, which affect surgeries, and the allergies. And the in social history, again, major 4 things to ask, and the occupation, smoking, alcohol, and how, where do you live? That is for the rehabilitation mainly, whether house or bungalow, and house the stairs. Those kind of things are very important, the post-surgical rehabilitation. And what do you expect from us? Is any surgical intervention? There's no point of talking about the surgeries. So we have to clearly understand what are their expectations before touching the management part. So how you examine the in physical examination, the look for the general appearance, whether it is syndromic, like Marfanoid features, and whether the patient is shoes, and whether there's any neuro in case of neurofibromatosis, and the both shoulders are appear at the same level, and both anterior superior spines, and the knees at the center of the whole body, and go to the cervical or lumbar lordosis changes with the degenerative changes, and flexion in the knees as a compensatory mechanism, and exaggerated thoracic kyphosis in ankle spondylitis, and we'll further discuss about spondylolisthesis later, and scoliosis. Any obvious skin abnormalities like scars, lymphoma, and capsular spots And we ask the patient to bend forward and see the Adams forward bending test, whether we have any doubt of kind of scoliosis, degenerative, or adolescent idiopathic scoliosis, or any other kind of things, whether to see rib hump is there. And then we walk the patient and see how patient walks, whether there's any foot drop, any Trendelenburg gait, or how's the pattern of the walking. Then we palpate the spine and see, we can gently tap over the midline. In case of fracture and infection, can elicit some pain with tapping. And palpate the facet joints bilaterally. If you can palpate, it's not if it is not the obese patient. And step sign in spondylolisthesis. When you palpate the midline in case of spondylolisthesis, we will see the step and we'll further discuss that. And in movements, we can see the cervical flexion, extension, lateral flexion and rotation, and lumbar flexion, extension, lateral flexion and rotation. How the spine moves, whether there's any lag of spinal movements. If you want to check on the thoracic rotation, you have to sit and keep the hands on the waist, hands on the iliac crest, and ask the patient to rotate, because we need to see how the upper body part rotates. So this kind of flexion, extension, lateral flexion, and the rotation are the spinal movements. Check on the movements. And special test. Always see the straight leg raise and Faber for sacroiliac joint pathology. How we do Faber's is keep on the supine position, and the figure of 4, we ask the patient to abduct the hip and bend the knee, and keep your foot on the other contralateral knee, and we press on the knee and see whether we are eliciting a SI joint pain. And Schauber's test for ankylosing spondylitis, again, we ask the patient to bend forward to see the actual spine is, it should give a value of around 5 centimeters in extension. So Schauber's test is to calculate whether the spine is actually ankylosed or not. In the neurology, we ask for shoulder abduction, elbow flexion, and elbow extension, and finger flexions, finger abduction, hip flexion for mainly L2, and knee extension, ankle dorsiflexion, big toe extension, and the ankle plantar flexion. So all these things can be done within 2-3 minutes in case of physical examination from the upper limb to lower limb, to exclude any kind of neurology or elicit any associated neurology. So in sensory, again, we can test on this, mainly the pattern of dermatomes. We check from the in case of upper limb, it goes like this. And the why the thoracic is important is to see in case of spinal cord injury. We know that amylase is at the level of T10. From there, we can get the T2. The sternal angle is at the level of T2. So we can calculate which level is injured, and we can see whether the patient is the ascending neurology or descending neurology is there. We have to clearly see whether the sensory level is there or it is corresponding with the motor level in case of the spinal cord injuries. So again, the reflexes, biceps, mainly C5-6, triceps, then the pectoral reflexes, we don't check much, and the brachioradialis and the finger flexes, knee and the ankle reflexes, and the plantar reflexes we check on. A set of reflexes need to be taken into consider. So we have a lot of causes of back pain, the mechanical back pain or leg pain. We have entity only with back pain plus leg or arm pain. Those are the major divisions, and the rest of the things are visceral. So most of our back pain is mechanical, and we have kind of visceral, and the tumor infection causes the rest of the 3%. So only 1% of tumor and infection will the lower back pain category goes only 1% of tumor to an infection. So that is to pick up those things very important. It again a complex issue. It has social factors, psychological factors, as we discussed, and the genetic factors are coming up, and the pathoanatomical features, as we discussed about the spatial arrangement of the spine in relation to pelvis, and the physical factors as well. So, although we are only considering the spine and the paraspinal muscles, don't forget about the referred pain. You can get the lung and the diaphragm in the higher thymus, in the back, upper back, and the spleen. The tip of the shoulder, and we know that gallbladder also coming, and the heart, stomach, liver, and gallbladder, pancreas, and we have the in the front the small intestine, ovaries, colon, kidney, and the ureters also, referring to the back. The referred pain also very important causes, because there might be no actual back pathology, but rest of the organs need to be considered. So what is back pain plus leg pain? What are the major things in back pain plus leg pain is the disc prolapse and the Cauda equina syndrome. We'll talk about the disc prolapse and so if you consider sorry for the interruption again. So this we were talking about the lumbar spine and the cervical spine, the mismatch is there. So the same disc, what I want to explain is if you have L4-5 disc, it should be, to affect the L4 nerve, it should be a far lateral disc, and to affect the L5 nerve, it should be a paracentral disc like this. So two different places, and in case of cervical spine, if you see the same disc could affect the C6-7. If you consider this disc could affect the the two places, whether it is central or foraminal, it affects the same nerve. So because of this mismatch and the horizontal arrangement in the cervical spine. So in locating the which disc is the pathological, this nerve root and the neurology of this nerve root affected neurology is important in the lumbar spine and the cervical spine. So in talking about the zones of disc herniation, we have the central disc herniation. Then we call this part as the subarticular, and it might be paramedian. And then we have the foraminal disc, and we have the extra foraminal disc protrusion. So in case of cervical spine, it is the pathology is different, and in lumbar spine, again, a bit different pathology, as we have already discussed. And so how common is the disc herniation? Mainly, our spine is the structure which causes the, which shows the aging changes early, and the disc herniations peak comes in the 4th and 5th decades. Males are more affected, and only 5% become symptomatic. So most disc goes unknowingly, and L5S1 is the most common level. 90%, 95% involve L45 or L5S1 levels. So you have axial back pain. It is discogenic or mechanical in nature, and can precede herniation even, because with the herniation, starting with the herniation, there are a lot of chemical gamut of chemical factors are coming up. Before the actual disc herniation, you might have discogenic mechanical or mechanical type back pain occur. Then you have radicular pain, buttock and leg pain, often worse with sitting. This part of the history is very important. Worse with sitting and improves with standing, and symptoms worsen with coughing, Valsalva, and sneezing, and pain not worsen with ambulation. And we have to exclude the axial. We have to take the features of the Cauda syndrome. In a minute, we'll come to the Cauda syndrome as well. So in disc herniation, the physical examination salient points we have just discussed. In inspection, the limited lumbar range of motion will be there. Pain is the limiting factor. So patient leaning away from the side of the radiculopathy, that is the effort to increase the size of the neuroforamen, not to irritate the nerve or spine list. Patient leaning away from the side of the radiculopathy to avoid the nerve irritation. So next is palpation. We can see the spasm of the paraspinal musculature, and associated tenderness may be at the level of the paraspinal muscles at the level of the affected level. Then we are coming to the special test, SLR, straight leg rest or Lesig sign. There's a tension feature for L45 and S1 nerve roots, and that is for L45 and S1, and we can put the patient prone and see. We can flex the knee and extend the hip in prone position, and it causes tension on the L2 and L3. If it is and the low motor of the imaging, the APL lateral radiographs, very important on standing. So see whether there's any anomalous vertebra, sacralization of L5 or lumbarization of S1, and the flexion and and extension to see whether there's any instance, very important affected area. We have to, at what point you are going to post-surgical or suspicion of MRI with gadolinium contrast. So some disc herniation is there. It could be lumbar, it could be cervical, it could be thoracic. So this is a kind of a central to paracentral disc causing the traversing nerve root impingement. And this is a cervical, mainly the foramen is affected, and this is a thoracic, the central disc. In case of thoracic disc, it could be large calcification to which the dura is involved. So what we do is we go through the uh, pedicle and reaching the disc without disturbing the cord, because in case of the lumbar spine we can retract the Cauda equina, but not the cord. So we have to go through the pedicle to get the disc out if possible. Otherwise we are doing the lamina, we are taking off the lamina to give some room for the neural structures in case of disc herniation in the thorax. Most of the time, we need not only the MRI, the CT to see whether there's any calcifications in the case of thoracic disc. So management in disc herniation is 90%. We don't need anything. So just give painkillers, exercise therapy, and it is, if it is in case of lumbar spine, it's 90%, and even more in C spine, simple disc herniations, they improve. Most of them not symptomatic, and it is new onset radicular pain. There's no significant motor weakness and absence of Cauda equina syndrome, no bladder and bowel incontinence. First line is conservative, rest, physical therapy, anti-inflammatory medications, and the limited narcotics, because narcotic addiction also there. And in the second line, we take the selective nerve root blocks with corticosteroid injections under real-time X-ray guidance. We can reach the foramen and give some steroids. Usually after 6 weeks, we wait for 6 weeks unless it is very, very painful. So as it's kind of an infection, introducing infections as a spinal procedure, so very rarely those things could happen. So it's long-lasting improvement in 50% of cases compared to 90% with surgery. And the third line is surgery, the microdiscectomy, discectomy, laminectomy, those kind of things are there. So for the simple disc herniations, don't ask for surgery straight away, because 90 to 95% in case of cervical spine and 90% in lumbar spine improves without anything. So this is the thing we should not miss, because in primary care, most of these kind of patients comes to the primary care because Cauda equina syndrome is a set of symptoms. There's a dysfunction of multiple lumbar and sacral nerve roots of the Cauda equina. The epidemiology is 1 in 3 in 100,000 population, but not to miss is very important. It totally changes the life if you miss because of the bladder, bowel, and the sphincter and the sexual functions, even if the motor and sensory improve. Uh, Sorry for the interruption of the connection again. And this is a kind of a very important condition. So the prolapse of the disc, the central disc, is the most common condition, and uh, there's a new thing coming up for the Cauda equina, mainly the Cauda equina interacting pathway. So it is a kind of thing you can look and see for the interactive pathway with this link. This goes GERFT guideline, get it right first time. And there's a separate area discussing about the primary care in Cauda equina. You have to see several things in primary care. What to ask the presentation is to primary care in Cauda equina is more than 70%. Ask about the leg pain, back pain, and sudden onset of bilateral radicular leg pains and unilateral radicular leg pain, and sciatica, maybe the warning symptom uh, before the actual Cauda equina, and sudden onset bilateral radicular pain or unilateral radicular leg pain has progressed to bilateral without Cauda equina symptoms uh, more than 2 weeks ago, also a sign. Then within 14 days of deterioration of any of the following symptoms: difficulty initiating nutrition or impaired sensation of urinary flow, altered perineal, genital sensations, and severe or progressive neurological deficit of both legs as major motor weakness with the lower limb neurology, and loss of sensation of rectal fullness and sexual dysfunctions could occur. If it is within 14 days, it's very important. It could be a Cauda equina, and if you do the right thing, it could be reversed. So remember the spine: sudden anesthesia, pain, incontinence, numbness, and emergency. Uh, uh, that is the one of the things we need to be remembered regarding this. And what to document: make the referral as urgent, and details of assessment of the patient, time and date of assessment, examination findings, physical examination, and the DRE, digital rectal examination, and the perianal sensations. If you do DRE record, the what to record is the resting anal tone, voluntary anal sphincter contractions, and the perianal sensation right and left. Get the MRI and CT if contraindicated in case of imaging with or without contrast, depending on the situation. So the basic management is urgent surgery as early as possible unless contraindicated, and rehabilitation with spinal physiotherapy team. The regaining bladder and bowel may not be possible, so we have to keep the realistic goals, and beforehand we have to discuss with the patient. You might get the motor back, you might get the sensory back, but you might not get the bladder and bowel and the sexual functions back because the autonomic nerves are very highly affected in case of Cauda equina syndrome. Before touching the patient, we need to discuss, and we need to consent, and we have to prepare the realistic goals and urgent surgery. In case of surgery, we do a proper large discectomy, and in decompressions, it might be laminectomy or taking off the a kind of a laminotomy, keeping some part of the lamina and taking out the whole, not the whole disc, the protruded part of the disc, and decompressing as much as possible. So there's an entity called scan negative CES. The patient comes with severe low back pain and pain shooting down one of both legs and difficulty passing urine, and those kind of the Cauda equina symptoms are there. But it is some pathological entity with the brain processing, brain and brain bladder feedback problem, and medications, depression, anxiety, and pain, poor sleep can cause this scan negative Cauda equina type of symptoms. And there's so much we have come across few cases and reduce mobility, exactly like Cauda things, education and physio and if back pain, analgesics, and to educate the patient. And there's no Cauda equina, and you don't have to worry about the rest of the things. And these kind of things, Cauda equina syndromes. Next thing is a bit different. Uh, the facet joint. Facet joint syndrome, we have discussed how the facets are affected if the spine is loaded posteriorly, and how the facet joint degeneration occur. So this pathology, this is a normal facet joint with a capsule, and it's kind of a synovial joint, and with the degeneration, you get the facet joint arthropathy. The pain, stiffness, limited range of motion, referred pain to upper buttocks, hips, thighs, knees, and pelvis, and they get sometimes headache, radiating pain to upper neck, and pain over the ear in case of cervical spine facet joint arthropathies, and muscle weakness on the affected side, and the tenderness over the facet. We have discussed these things in spine examination. So how they refer the disc versus facet pain is mainly the if it is a lower disc, lower facets, they refer mainly to this area and to the buttocks, and they refer to the posterior thighs and upper calf, but it is not coming to the not the radicular type, but they're not coming up to the feet. So in case of cervical, again, you might get headache. There's no cause of pathologies in the neural elements, but because of the facets degenerative changes, you might get, because medial branch is the one affecting the facets, supplying the facets, and causing the referred pain over in these areas. So what is the disc versus facet pain? The pain location, often midline of the back, and can radiate down the leg. In case of disc, we call as sciatica. It is a non-specific term, and it is localized to one side of the back, and usually near the affected joint in case of facet joint. And in pain quality, sharp shooting and burning sensations, dull leg stiffness, and aggravating movements, bending forward. And in case of facet, it is bending backward, twisting and extending the spine, and relieving the movements, gentle back extension, gentle flexion, relieves the facet. The numbness may be associated with the disc and muscle spasms in the back, and herniated disc and disc degeneration are the causes of the disc pain, and the facet joint degeneration and arthritis are there. So MRI scan shows the disc. Again, the MRI or X-rays, we can see the disc facet degenerative changes with the fluid filled facets in case of facet joint pains. So how to manage the facet joint pain? The facet joint suspected based on the history and examination, and differentiating from disc pain and the medial branch block with short-acting anesthetics. Initially, we have only three kind of treatment in spines. One is the analgesics, exercise therapy, and the physical things, and then we are going for nerve root injections, nerve root blocks, and then the surgical procedures are coming. So to get rid of the pain, we initially give with the short-acting anesthetics, and then with the long-acting anesthetic and the radiofrequency ablation, or to get rid of the medial branch block, which is supplying the actual facet. So next is the spinal stenosis. That is also very important. We just discussed about the neurogenic claudication. What happens is because of the degenerative disc disease in elderly, this is a normal disc, and you can see the white marks of the normal disc in the MRI scans, which has water. Here it is no water, all black disc coming up and pressing on the neural structures, the Cauda equina structures. Here, what happens is the spinal canal is compressed from the front as well as from the back because of the degenerative disc disease. It causes more burden on the facets and hypertrophy of the facets and the posterior structures like facet joint capsule, facet joint itself, and the ligamentum flavor all causes this black ball and compressing on the neural structures, and from the front it causes the disc, the degenerative disc is compressing. So spinal canal actually narrowing the area for the neural structures. So it causes the spinal stenosis and neurogenic claudication. So we have to differentiate neurogenic claudication or pseudoclaudication. The symptoms are pain when standing, and pain when walking, and pain when sleeping, and relief in forward position also occur. Pain or numbness in the lower limb when standing upright, pain, numbness, heaviness can cause in walking. Sometimes they get heaviness in the legs while under the shower, not even walking, and pain with lying down can also cause this claudication type symptoms. We have to differentiate from the vascular claudication, the cramping in vascular ears, but cramping is not there in neurogenic. Tingling in vascular may be there. Tingling is more prominent. Numbness is there. This actually not just true. Nerve roots might be affected. There may be no leg pain. There may be leg pain, but the neural that's why the neurogenic claudication occur. Pain is there, and the pain intensity is constant, and the dissipation occur in 1 to 3 minutes. They bend forward and start walking. That's why the shopping cart side needs coming up with the neurogenic claudication. So next is the spondylolisthesis, which we call this entity as the forward progression of the spine. There's a area called pars interarticularis, because this is the part in between the superior and the inferior facet, the bony bar in between the superior and inferior facet, we call as spondylolisthesis. All are the tongue twisters. So what happens is there are several causes. If it is L5S1, most of the young children are affected. Dysplasia of the neural arco sacrum is there. The upper facets are of the neural arc, and there may be stress fractures causing the in the pars interarticularis, elongation of the pars, and the SMIC and the pars fractures, and degenerative changes may be there. in type 3, and the traumatic, the pedicle fractures can cause traumatic spondylolisthesis, and the pathological in case of tumors could occur in the in case of pathological types. So in the healthy spines, we have 4 grades of spondylolisthesis. Grade 1 is 25%, 50 to 75, and then grade 4 is more than 75. There are several etiologies associated with the spondylolisthesis. Again, listhesis and the spondylosis and spondylolysis, which are the vertebral stripping and forward progression. And losis is degenerative changes in the spine, including osteoarthritis, changes in the facets. And the spondylolysis is the stress fracture or defect in the pars interarticularis of the vertebra. So that's what we were talking about, this step sign in L or slit sign. When we are examining the patient, we can see this L shape. The lower bar is here and the upper bar is here. So you can just palpate the spondylolisthesis in spinal examination. So it is if it is low grade, we don't have to do anything. We can manage symptomatically, and if it is high grade, we have several options like this: spino-pelvic fixations, spine and in situ fixations, and if you reduce, you might get some neurology. So in situ fixations may be considered in some cases, and so we have to stop the forward progression. We need to posterior only fixation. There may be interbody fixations. Those kind of things can be done. So identifying this is very important. This is one of the conditions which could cause the neural structure, the neural canal narrow. So cervical myelopathy, if you get a single one single condition in our setup which is not very poorly addressed, and people are not considered, that is cervical myelopathy, because the emergency somehow reach the hospital and get operated. But cervical myelopathy is a different entity, which people are affected, elderly affected, healthy elderly, the population is affected, but they are not coming to the medical care. Here, you're going on with some neck pain, and then you start dropping things. Hand dexterity is going down, your handwriting is going down, and the using the small tools initially goes down. The pens, the screwdrivers, those things are affected. Then what happens is your eating is affected. In the Western countries, they use the fork and knife and the spoons, but so they understand that now they can't use that anymore because of this hand dexterity is going down. Then the hands are affected, then your balance is affected, then your bladder and bowel is affected. So unless that progressive stage, they don't come into the medical care. So early identification is very important. So this is the normal MRI cervical spine, and what happens is you're compressing anteriorly, as in the case of the lumbar canal stenosis. And here again, you have pressure on the spinal cord, and you get the cervical myelopathic features in the cervical cord as well, destabilizing the cervical spine. So there's a history elements we have to get into this in primary care. The upper limb motor, lower limb motor, upper limb sensory, and the sphincter functions. So there's a scoring called MJOA history, and one is I'm unable to use my hands, and the feeding and buttoning shirt and handwork normally. We don't ask about those things. Then lower limb motor, I'm paralyzed, feeling of my legs gone. They're staging. This is the thing. Whatever the radiology says, the severity. This is the actual severity. So we decide on operating these patients based on the MJOA history. So this is a progressively deteriorating condition. You can't reverse the things, but we saw some reversal when we operate. Early identification is very important because there's we can see they come with the pain, paresthesia, stiffness, and the losing of hand dexterity, and the Romberg's test, Hoffman, and the inverted supine sign is there. So we have to examine, image, and then decide on what kind of surgery to go ahead with. If it's unless contraindicated, we can do anterior surgery and posterior surgery, or combine anterior or posterior approaches to relieve the spinal cord. So assess the gait. They don't have. They can't do the tandem gait. Or catwalk. Go ask to go on the line, and they wobble. Then the gait is affected. So then check on the Hoffman's. Check on the Romberg's. Check on the reflexes. Some idea about the long tracks. Long tracks are affected, and your balance is affected, and the cause is the neck. So very important entity in Sri Lankan setup. It is 90%, more than 90% are very, very poorly addressed. This is a single entity, as I said. It is very, very poorly addressed because it is not identified from the. They don't come to the care mainly unless it is very, very progressive stage. They are totally paralyzed, sometimes bed-bound, chair-bound, lose the bladder and bowel control, and then only they realize there's something going on, and they come for the medical care. So just to touch on the spinal tumors and infections, because those two are very important entities, and we have a set of spine, the intramedullary and the extradural tumors are there. So most of the intradural tumors are intramedullary and extramedullary. Extramedullary, again, more tumors are there. In the extradural, we have the metastasis. That is one of the intradural and extramedullary tumors, unless it is huge compression, because this causes neurology, this causes instability of the spine, and as in the other metastasis to the bone, it causes breast, prostate, lung, thyroid, and bladder. Those are the carcinomas, mainly goes to the bone. And the survival, you can see, lung has very poor survival. It is around 6 months, and then the melanoma also, although not we are not describing much, again, as a very poor prognosis. So identification of the things very important in case of tumors. History is the key, as you said, history of cancer, physical examination, neurological examination, and the bloods, MRI, CT chest, abdomen, pelvis. If you don't know about the primary, and some units do cerebrospinal fluid analysis for cytology and the bone scans as well to see the spread of the disease in the bones. So why they get the night pain? That also important, and they get the hormonal changes, the cortisol. We are talking a lot about the night pain. So they get the hormonal changes, circadian rhythm, and the sleep position. reduced distractions and the cumulative stress causes the night pains. Because of this, they feel the pain in the night in case of these tumors. So in the most of the bone mets occur in the thoracic spine, and some involve the multiple segments rather than the cervical and the lumbar spine. You might get a single met like this, and a pathological fracture like this, or multiple bone mets involving the whole spine as well as the bones like this in some cases. And we have addressing of the management, that's called norms framework, and that is we have 5 things to consider, mainly the 4 things. Norms is the neurological status and the oncological tumor behavior, and mechanical stability, systemic disease burden, and the medical comorbidities of the patient. Depending on the norms, we are going ahead with the operation to fix or going for radiotherapy, and chemo radio, the oncology pathway or the surgical pathway, depending on the case of the norms criteria mainly. So they consider these 4 factors to give either radiotherapy, surgery, local like en bloc resections and get rid of the cancer in the spine, or else we can do the stabilization anterior or posterior to keep the spine straight. So, and just to touch on the spinal infections, who's at risk are the people who are with diabetes and other medical comorbidities, malnutrition and age population, intravenous drug users, obese, all those with some other cancer or transplant, they are they have high risk. And there's an entity which with the transplant associated spinal infections, and there's a trilogy of infection. You have to look at on this trilogy. They have spinal pain in the 67% of cases, and the fever and the neurological deficit in motor, sensory, and the sphincter function. So rest of the red flags also coming into play: the age less than 20 or more than 55, pain in recumbency, constant progressive non-mechanical pain, fever, neurological deficit, and deformities also coming, thoracic pain, immunosuppressive illness, and the tenderness to the palpation and percussion also there. So there are several type of infections: discitis, spondylitis, and spondylodiscitis, septic facet joints, and the epidural abscess. Those are the spinal infections. So in the case of bacterial infections, they start with the disc and they progress the edge of the anterior edge of the just above the end plate, and then they progress to the disc, and then they involve the upper and lower end plates, then the vertebra, causing the vertebral osteomyelitis and the destabilization of the spine, and causing the abscess here, and finally infection, spondylodiscitis, and the abscess. This is the order they are going in. So spinal infection in the early stage, we can see the narrowing of the intervertebral disc spaces, vomiting, destruction, absorption of irregularities in the progressive, and the healing stage also there. So spinal abscess could be there, and the discitis, spondylitis, and the paraspinal infections are there. You can see this is the discitis and the vertebral body osteomyelitis, and the spondylodiscitis involving both the disc and the vertebra. In case of the most of the time, these kind of pictures comes with the bacterial infections, the bad disc, and then only the this you can see the disc, and this involves rest of the vertebra later in case. So what happens in TB or Pott's disease? They comes with sometimes history of TB It's a bit different from the normal spinal infections. The TB goes in the line of uh, the same as the tumors because it causes the same constitutional symptoms, fever was at night and the fever malaise, and there may be a cold abscess and neurological deficits may be there. So mainly they get if you get the picture, that is the commonest extrapulmonary manifestation. So you get the good disc and the bad pathology combination in case of the tumor in as in the TB. So what happens is you get your disc is spared, your vertebra collapse. So you have a good disc and a bad pathology. So finally they form the gibbous like formation like this. If you have the early, in case of early without instability, without neurology, mainly medical, go for the respiratory physician and start on the TB therapy. The early identification in primary care is also very important because history of TB, the long-standing cough, there may be no pulmonary signs on in case of the spinal or pulmonary TB patients. If it's going to the bone neurology, we are addressing surgical. So this is a last slide on this presentation, just to spinal TB and the pyogenic spondylolisthesis and the metastatic spine disease. So what happens is this is dorsal and pyogenic maybe lumbar, and the metastatic is again dorsal. And you have exposure to TB and risk factors. So you have good disc here in TB, good disc here in metastatic spine, and the bad disc in the pyogenic spondylolisthesis cases. So bad disc, good prognosis, good disc, prognosis is poor. Just remember that part. Thank you very much, and very sorry for the internet connection interruptions, and I'm okay for any questions.
It seems we don't have questions today, sir.
All
So
right.
on behalf of the college,
Yeah, if anything, I'll post my email. Just email me.
thank you, sir.
Thank you very much for listening, and very sorry for the internet connection interruptions.
Okay, on behalf of the college, Sri Lanka College of Specialist Family Physicians, I would like to thank our resource person, Dr. Anuradha, for delivering such an important session. Actually, when I was listening to this, I felt it was tailor-made for those who preparing for the exams, mainly, and also for the primary care physicians, of course. I'm sure our MD trainees and other people, other doctors sitting for primary care exams must have found it extremely valuable, as every slide was important, sir. So thank you so much. Although we faced some interruptions due to the connectivity issues, the session will be uploaded to our YouTube channel, SLCSFP, either tonight or probably tomorrow. So please subscribe to it, and then you will be able to have the access for this important session. And dear participants, so kindly remember to fill out the Google form to receive your certificate. We also submit the participants list and details to the National CPD Committee link of the Ministry of Health. So your certificate will only be valid if your details are correctly filled in. So please do that. And we look forward to hosting another important session, probably at the end of this month or in April, first week of April. Until then, have a great time. Thank you and good night.
Good night. Thank you very much.